Good morning and welcome to today's webinar on shared care record implementation, the journey to success, hosted by Channel 3. At Channel 3, our mission is to improve the lives of people, to enabling care professionals to deliver better care through effective use of digital technologies. We say better care, better lives, better care, better digital. I'm Martin Tennant, partner in the firm, and I lead our shared care practice. For Channel 3, shared care records are at the heart of integrating care within ICSs and across all the different care settings that individuals interact with. So today's webinar feels really timely, given the launch of the new version of the Data Saves Lives strategy, which is really underpinned by shared care records, and it's mentioned many times in that document. We're joined today by three people who are intimately involved in delivering shared care records and have been for a number of years. We've had the pleasure of working with all three over the course of our work at Channel 3. So with no further ado, let me introduce you first to Laura. Laura,
Hi.
Good morning.
Hiya, good morning everybody. So I'm Laura Gottschalk. I'm the Leicestershire and Rutland Care Record Programme Manager up in the middle of the landlocked world here. What drove my ambition to work in the healthcare sector is that I have a large extended family. A lot of them work in healthcare, in either medical or social care in one way or another. My mum's a nurse, and I hear about her experiences, including her frustrations and her difficulties that they face on the front line. And I'm always really conscious that nobody goes into the medical or care field to be sat in front of a screen and typing away. So I always think to myself, would my mum find this beneficial to support her in caring? And would she actually have the time to do this? And that's always kind of in the forefront of my mind with all of the projects and programs that I work on. My first role in the healthcare field, so I've always had a keen interest in mental health. My degrees are in psychology and clinical criminology, but my first role within the NHS actually was on an EPR implementation into our mental health and community trust, doing configuration and training to the frontline staff. And it gave me experience to talk directly to them to see what they actually needed and to be able to tailor that system around their day-to-day and their processes, rather than something being implemented to them and something that they had to change their local processes to accommodate. So I'm always really conscious of that, trying to integrate and streamline within the things they already do, rather than trying to create this extra thing, something else to find time for. A bit about me then. So outside of work, I'm a rogue swimmer, if you like. So I'm happy in any body of water that I can find and get into. But I just generally love being outside and take every opportunity to do that, really. So it's nice to be with you all today. So thank you for having me.
Thanks, Laura. It's great to have you with us. Next, let me pass over to Una. And Una, you're up in Liverpool at the moment at Confed. So good morning and welcome.
I pick up a lot of, so shared care records are a big part of my program. I pick up lots of other pieces of work around things like care provider digitization, aging well, virtual wards, all those things where cross-organizational collaboration is needed. I came into the health system accidentally. Job whilst I was attempting a career change. I started in finance and banking, and I decided I was going to be an osteopath. And so I came to Oxford to study to be an osteopath, and I got a nice temporary job in the NHS. And here I am 12 years later. I of people, and I think so. I've always worked with really exceptional, enthusiastic people who are really all trying to do their best for our citizens, whether that's colleagues in the team or clinical staff. And then purpose. I think working in this arena where we're trying to solve those boundary problems is, and do that information sharing piece is our users need and want it. We're not foisting something on it. They're demanding, they're pulling on us for this. My first ever job in Oxfordshire in the health service was implementing System 1 into our out of hours and MIU service. So I spent a summer in a port cabin in Abingdon Community Hospital, for anyone who knows it, phoning System 1 and trying to bed. It was a proof of concept at the time, and I've kept System 1 with me in every project I've done since. They featured, but immediately after that, I got involved in the first instance of an Oxfordshire shared care record. So at the time we were rolling out summary care record in Oxfordshire, we also started an implementation of what was called the Oxfordshire Care Summary at the time, and it was a locally built bespoke care. That was 2011, 2012, so really one of the early prototypes, if you like. And a bit like Laura, I live in South Wales. There's lots of hills around me. I like mountain biking and a little bit of wild water swimming. So I'm hoping to get Laura down here sometime and show her the sights. Thank you.
Absolutely.
Brilliant. Thank you. And I suspect that you are facing some uphill battles with connectivity in Confed as well. So we'll battle through. Turning to Astrid, with me in the room, so no such connectivity issues. Astrid, let me you introduce yourself.
Thank you. I'm Astrid Fairclough. I'm Programme Director for Wessex Care Records, but also for Dorset Care Record and the CHI Shared Care Record in Hampshire Isle of Wight. So that's a joint role across the three partnerships, but 2 shared care records. And running through similar aspects, I slightly accidentally fell into a career in the NHS, as Una did, and I'm going to combine those first 2 questions all at once, because my first job was in my gap year photocopying for some of the projects around Agenda for Change when it was introduced way back then. And in a couple of weeks I went from a sort of temp photocopying, which teaches you all you really need to know about the NHS in our kind of world. Obviously, not in a very in a front line role. But if you're interested in a career in working with our clinicians, I think photocopying is a very good place to start. And so I started working through HR onto projects fairly quickly, and have stayed in various projects in and around often smaller groups, so armed forces, violence and abuse, female genital mutilation. So often, how does the NHS, the big beautiful beast that we all love, how does it care not only for everybody that you and I might think that we have in our families, but there are so many parts of the NHS that are unique, that are special, and it's phenomenal, I think, how it does the specialist services. But so I've often worked in around sort of linking up boundaries between those kind of areas, so that and I love the new focus around health inequalities as a result, because having worked in those kind of areas for a number of years, so sorely needed, which brings me into the shared care record world, really, because it's, I think, a fabulous combination of the two, where we can actually focus on, and what drives me around my health work in the health service is really about that, because, like Laura says, we've all got families. You know, my mum is currently testing why we need a shared care record. And so it's not necessarily the start of my career, but those kind of things do help us keep being motivated. And so I think it's that sort of mix of my life, the lives I work with, and the people that I know that keeps us going, keeps me going. What do I do outside? I tend to stay above the water mostly. I row, sea rowing. Do like a dip in a bit of cold water as well. So I don't know if that's something to do with their record leaders like cold water.
We're gluttons for punishment.
Yeah, I feel so sedentary compared to the three of you, and almost averse to sort of getting my feet wet in the slightest. So, but ladies, thank you all for joining us today, and really looking forward to today's conversation. I'm going to first to the first subjects, which is about starting strongly. And I'm going to turn to Laura. Laura, like any other program, making a strong start to your Shared Care Record journey is pretty vital. So you've been leading the program in Leicestershire and Rutland. What did you set out to achieve for your Shared Care Record across the NHS?
Well, within Leicestershire and Rutland, we've worked on sort of multiple initiatives over the years with the aim of overcoming communication barriers between organisations and trying to work more closely together as well, such as data sharing between primary and secondary care, or our care homes and GP, which is something we sort of kicked off just before COVID, really, and that rolled into and really helped us services during COVID as well. But there's never been really one solution that worked for all of us because of our differences in our digital landscape across the region. But the appetite and the energy was definitely there from all of the organisations to make this happen and have this one entity that would suit everybody. We needed something that had the ability to support local, regional and national strategy going forward. But our main objectives were to join up health and care services, listen to the priorities of our communities and tackle some of the biggest challenges that we had in or have still in LLR, which is improving the health and well-being of our population, the quality of the care that they receive, and ensuring that actually we're spending taxpayers' money on something that's right for them, not just now, but also going forward, and have something as an investment of that as well.
And by the time you started on your Shared Care Record journey, there were already quite a number of Shared Care Record implementations underway and in place. Where did you go for advice, and what did you learn from others?
Well, we were quite lucky, and rather than buying into another, I mean, we looked at so many different systems, but we were quite specific with what we wanted, having done so much work already within LLR with sharing information. And rather than buying another system, we chose a shared ownership model and joined a partnership with Yorkshire and Humber Care Record of using Interweave, a platform that's something built within the NHS for the NHS. And joining that partnership actually enabled us to do a lot of collaborative support network with Lee Rickles and the colleagues up in Yorkshire and Humber. It meant that we could leverage existing cross-boundary relationships and share good practice between us as well. Developing ideas for the future roadmap and having something that we could tailor that actually works for us as a whole, and how we can adapt something going forward that works. We benefited from the expertise of our software developers, which is Synonetics, and the knowledge and experience our colleagues from Channel 3 actually bring to our programme as well. That's definitely benefited and helped propel LLR forward from only starting our programme last April right through to going into pilots literally tomorrow. So it's been a real sort of whistle stop through in our time frame so far. But also, I don't want to underestimate the support and collaborative approach we've had between our organisations nationally with the National Shared Care Record Group, which is actually facilitated by Astrid in the first instance, and she chairs that. And I know that we've definitely linked in with other areas connected to that group as well, and have worked collaboratively with our system suppliers as a collective. And that gives us more oomph as well with going back to our system suppliers. So actually, it's not just us that need this, it's all of us that need this. And that helps sort of to push their roadmap as well, the way we need it to go. And make sure that we're not reinventing the wheel for every single ICS, because that's a huge amount of work to keep doing over and over.
Yeah, good luck tomorrow with the pilot, by the way. And what's been your biggest learning so far with the initial phase of the programme?
I think it's actually probably that not to reinvent the wheel. Build on existing structures that already work, whether it's locally or nationally or another area. We're all trying to do exactly the same thing, and we were trying to realise the same benefits and overcome the same challenges. There are going to be differences between some of the regions, but ultimately starting with something that's already proven is always more productive than starting from a blank sheet of paper. And sharing things that work well is always sort of a much better place to be, and makes the world feel slightly smaller when you know you've got support from other areas. We've thankfully been able to avoid a lot of our pain points by utilising lessons learned elsewhere, and we're now at the point where we're able to pioneer in our own developments locally and then share that back into the pot with other organisations as well. I think COVID actually, for all of its bad points. The good point is that it's allowed us to be a lot more open and connected with other areas and people in other localities, not just nationally, but also globally. What are people doing elsewhere? And sort of just kind of build on other structures and link in there just to make things more productive and more efficient.
Yeah, and one of the things that strikes me about the Shared Care Record community, of which this today is part of that conversation, is it is a group that draws on this wisdom of others in a way that sometimes we haven't seen in other parts of the NHS, and it's a fabulously rich group, and I hope this conversation contributes to that. Thank you, Laura. So we're going to move on to Una and talk a little bit about, once you've started strongly in your journey, how you build success into that. So Una, you draw in Gloucestershire across a very wide range of data sources. What have been the major sort of technical challenges to bringing data together from across the different components of the ICS, and in your case, often beyond the borders of your ICS, indeed beyond the English borders?
Sure, yeah. I've come up with a high-tech solution to hopefully my difficulty hearing me the last time. I've stepped outside the building, so hopefully that works. Yeah, I mean, the funny thing about Gloucestershire is we are a small ICS. We're co-terminus. You know, we've two trusts and a council, and our CC, you know, we're relatively small and simple compared with other areas. But within that, we've managed to mop up most of the major clinical systems, and so as a shared care record, yes, we're integrating with quite a few, and more so, no two integrations are the same. You know, we're having to use different connectors and different methods to draw data from the different source systems. So whilst I suppose my you know, number one challenge that I put out there is that thing of common standards. And I know we have the MVS that's been published. We've had Interopen historically. Our standards are not yet specific enough for suppliers to work to and for us to hold them to as a collective, and so really at the moment our suppliers and providers are kind of determining how those connections happen and what the scale and scope of them is. So really that lack of specificity around our standards is one of the big challenges. I think the second one that as we investigate further the data that we're sharing and what's in those data sets, and the kind of data quality and appropriateness of some of the data we're sharing. And I suppose if we think back to the purpose for which that data was input, wasn't necessarily for it to be seen beyond the person who typed it in and a couple of other people within their organization. So it is often, you know, potentially not written or formatted in a way that means it makes sense to anybody consuming it outside of that setting from another discipline or another profession. And I'm talking within health, not necessarily across, you know, then you factor in social care and care providers. You know, it's difficult, you know, it's difficult to do it really, really well, to raise the data quality and data appropriateness of what you're sharing. And then into that comes the kind of nervousness around at provider level, maybe your kind of information teams and your data teams around, again, that they're kind of purposes for which they're curating the data and then sharing it onwards to us. So it's that tension between the kind of provider priority in terms of data management and the system priorities in terms of data management. And it will be interesting to see as we move to an ICS whether that tension between organization and system is that kind of mindset shift happens, I suppose. So there, and then of course the last one, which, you know, we can't talk about shared care records without putting the letters I and G together, and you know, what things were close in terms of direct care and the requirement to share care versus the balance for, you know, against the privacy and confidentiality. we have a ways to go to really clear up a lot of this kind of contradictory and confusing sort of policy and regulation around it, and a lot is up to local determination. So when you start to stray into population health management for direct care or otherwise, you get into some sticky waters. And I was very happy to see Professor Goldacre agrees with me on that. He set that out very nicely in his report recently as a challenge that collectively and nationally really we need to resolve.
Yes, you are in good company with Ben Goldacre there, and I think one thing Ben probably highlights, and I think you've probably had to face a lot of it, is the amount of cultural change you've got to go through in educating or encouraging, or there are so many words to use, your organisation. How have you done that? How have you encouraged your those organisations' individual responsibility for data to be involved in the shared care record?
Sure. When if I think back 7 years, we came here to a very tiny team and no system level structures. So we have many platforms like our countywide information governance group, our countywide digital boards and groups and so on. It's all very well getting agreement at exec level, that's in some ways, and board level, that in some ways that's relatively straightforward. It's then the on the ground, the colleagues that you're working with and actually making this happen. And interestingly, so I would say building trust and relationships is what that is all about. And that's been a real theme here at Confed, actually, with every session where there's anything to do with data and information sharing and working collaboratively. It's all about trust and relationships. If you get them right, everything is easier. If you haven't got them, it's an uphill battle.
So Una, thank you. I'm going to turn to you in a second. And actually, as Una just said, that building the trust is so essential for integrated care records, shared care records. Trust on the ground, trust from patients and carers, just as much as it is from those who manage and own the data from which we draw. In Dorset, and Wessex more generally, you've been alive for quite some time. How do you grow the usage of shared care records across the patch?
Sometimes we've learned as we go. So there's a couple of things that I think have worked really well. In earlier days, we were, as I say, a couple of years ahead of the sort of national drive. So I know that there were a number of very similar initiatives. We weren't necessarily fully linked up, and I think so one of the lessons that we look back at is recognizing that we need to be respectful of the complexity of the shared care record, that you give, but you don't necessarily receive by giving. Now, the reason I mention that is because of the way it relates to implementation. So say we have just got acute A to give all of its information. We don't necessarily follow up with acute A about how to make sure it's being used. You've got to go over to acute B or to the GPs or to somebody else at that next point. And I think there's an element of it was quite tricky to see that on those earlier days, and to sort of promise everything to everyone. And it's actually very incremental. Well, for us, it was incremental to be able to offer something valuable to different groups as we went. So I think we learned that pretty quickly. Something that I know Dorset Care Record is really quite well known for is the case studies and the stories. Yeah. And it's amazing. We all know that we all go to a conference and we hear a great big talk about this, that, the other, and you go home and you tell your team about the story that they began with. And that's what has really helped an organic approach to growth within Dorset Care Record. So we had definitely quite a period where we sort of learned a bit about making sure that our offering was clear and that we weren't going to have everything on day one. So that was the first stage, but using the case studies has allowed a really organic approach through different organisations, different ways, tied in, we hope now, with that SSO being turned on and then a big push coming within that organisation. But that has got us to a really great place. Like every other shared care record, we exploited hugely the pandemic and need for sharing care records. You've all got to take what you can.
Thank
So,
goodness for the Kobe notice.
I mean, isn't that a whole 3-hour seminar on its own? But so yeah, of course we benefited from that, as so many have, and isn't that a terrible thing to say, actually? But you know, we've got to take the silver lining, and shared care records, I think, is one of those that we will have to protect into the future. I'm not going to steer off there. Sorry. So the organic growth was amazing. It gave us a real focus around the pandemic to sort of build that actually quite a bit. What we've been doing quite recently is about analysing our use, because that's got us really far. We can see SSO leads to massive push there. We can see that effort there leads to massive push there. But where are the gaps now? So if we know that case assessment teams love a shared care record. They want portal access, they can look through, and we've got the audit in place, so we're all good on that. Great. How many assessment teams have we got? We've got 3 of them using it, and we've got 12 not. Well, that sounds like a bit of effort to go in there. And so we're starting to analyse our use so that, and work with our partners to own the implementation plans themselves. Because again, my perspective as a centralised team isn't going to be able to encourage the users. You know, we've got CCG email addresses or council email addresses, and you get into the monthly seminar, the monthly team meetings, the intranet in the staff room that tells you to use this, that, the other system. You only get into those things if you're part of that organisation, or it's easier to. So making sure that our partners are owning this next stage of implementation, to see their gaps, to see where they're going to be able to put that effort. And again, we're using a lot of stories within our partnership. So not only do we have the stories to encourage our users, but when one organisation has done a massive push with a huge result after an SSO, we bring that to the fore so that we're showing it. So again, trying to be growth, looking at our gaps, trying to sort of take it as logically as possible. It's still very difficult to know where the ceiling is going to be.
I hope the ceiling is, you know,
well,
a long way away.
And I think we almost might accept it to be lower if we stop challenging ourselves.
And where is the next stage of development for your care records?
The bits that I think are really exciting is where we get to work closely with our transformation efforts across the ICS. And we've got a couple of these projects where we've all got something like a home first, or a shopping centre that's been turned into an outpatients transformation centre, outpatient centre. And so these amazing initiatives are going on in every ICS, and we're working out how to work with those transformation efforts. I use the example that we've got, we're actually in the very early days of our pilot of our personal health record. So my DCR is now our citizens' ability to log in to a shared care record. So we've got pilots going there, but one of the areas is with Dorset Cancer Partnership, where we are being the mechanism to communicate with the patient. And across the cancer, we've got those initiatives to have reduction of 20% outpatients, or the reduction in this, that, the other, the change in pathways, and they're very difficult to achieve without using digital or different ways of communicating with the patient. So some of our really exciting projects are with those transformation teams. How do we get into them quickly enough is difficult, but many of them want to have something that looks awfully similar to a shared care record. So rather than recreate, so it's about getting in early, making sure that that's the go-to point. So we've got sort of your services that are up and running, and that's our first phase. But then our next bit is then we can allow changes to happen because you've got it all in one place ready. So you haven't got to spend 3 years building it. And that's where we've got all sorts of initiatives, and it's going to be difficult to keep up with, probably.
And that's a good problem to have.
Yes.
And that patient health record piece is really interesting because data saved lives, the change to data saves lives, one of the very obvious changes is the use of shared care records to support patient-generated data and patient and carer access to their own information, and seeing the shared care record almost as the conduit for that. That's a real step forward, and I mean that could be a vast increase in the usage of shared care records if that comes on board. Ladies, all three of you, thank you for taking time to talk about those questions individually. I'm going to move to the final stage of today's webinar to maybe ask some questions of all three of you. There's some questions coming through the chat which I just want to cover now. The first one that's come through is, does shared care records support the move to integration and data standardization reporting? Now, we touched on this a little bit, and Una, you've talked about it a little bit, but Laura, integration and data standardization and using it for reporting. And what's your view on whether shared care records support for that?
Yeah, I mean, data standardization has been a key focus within LLR, and historically we've tried to work together for a number of years to try and get a consistent approach across local health organisations, especially within the coding behind our systems. We've been trying to streamline that between our services for quite some time. We wanted to continue to strengthen that within the LLR care record. The programme's had a real sort of emphasis on adherence to regional and inter-regionally curated standards. And this not only helps with consistent sharing of common information resources between organisations locally, but also helps with future-proofing effectively for when we start looking at cross-regional boundaries going forward. So yeah, I mean, data standardization is something that's really key, and we've done quite a lot of work with PRSB as well and other organisations looking at data standardization across how we can manage that nationally as well. Yeah,
and PRSB, I know, who are joining us on the webinar today, part of the chat, very important. Their contribution, we're doing a lot of work with them at the moment. Astrid, your thoughts on standardization?
I think the way you asked it was, can shared care records help standardization? And it's such a circle.
Yeah.
Why? There's an element of me that just wants to say, why should we help? But I do know that collaboration leads to that. And that's probably born out of a bit of frustration of when it's not there, you jump ahead and you fill it in anyway, because you've got pragmatism that comes into the health and social care sector, and if you can get that information, there's not a standard there, you do it. And then you build up a legacy of challenges for you to lead. And then you're presented with the ability of, well, a limited pipeline to take on new developments. And we have to give up really valuable new development time to address the challenges that we have built into our system by using the best standard that we had available at the time, which is no longer current.
Yeah.
And that, you can probably tell, provides quite a lot of frustration because it's building, and I look at, we talk to the shared care records coming, and it's still the scenario. So we are still jumping at such pace with sometimes our, standards that are brilliantly forming, but it's really, really tricky space. So yes, we must be part of it. We must collaborate. I love the way that Yorkshire and Humber and the wider collaborative with Leicester and so on are testing and publishing that open standards that was probably focused on more a couple of years ago and doesn't seem to be the trendy phrase at the moment, but why not? Probably needs to be one of the trendy phrases, because we've got to learn, we've got to test fast, and so our standards part of it, absolutely, because we're close, want to stay close to being able to interoperate between our two shared care records. We're trying to build a future so that we can do that with others, and the standards, if we're not using the same standards, we won't be able to do it.
Yeah, I mean, one of the things I always say about shared care records is they almost inevitably, by the fact they are pulling data from many different sources, shine a light on data quality, and where data quality is not to the level we want it, and standardization. Una, I think you've always seen data quality as one of the big challenges you face in Gloucester is getting that consistency.
Absolutely, and I think for our rightly or wrongly, we probably built our rod for our own back with our design. So we did a development project with our shared care record supplier, and we went the road of blended views. So bringing rather than showing each source data source separately, we'll show all the medications together, all the diagnosis together from all the different sources, and boy, does that shine a light on the differences in the sort of data structure and data lack of standardization, and every so often we say, is this right? Is this too much? Is this too hard? Do we keep going this way or not? And so I would agree with what you just said, Martin. I think we can shine a light on it, and I think listening again to the conversations here about sort of data strategy in the future, I think we can contribute through that shining a light on it, how we actually arrive at good quality kind of standardized data sets for the various purposes for which they're needed, whether because there's timeliness as well for the purposes of care. It needs to be there now, but if we're talking about using it for analysis, there's time to work on it. Yeah, it's a big, chunky, problematic. Health data is messy and complicated.
Aspen, I know you want to come back on that.
Well, Uni, what you're just saying about how we've built, created a rod for our own back by creating that normalized view and bringing it together. I know that there are differences of opinion, but isn't that a shared care record? Because otherwise you've just got a lot of little bird's eye views, and you start thinking, okay, an ICS with 2 acutes and a CCG and a community mental health, you can cope with 3 or 4 different views. But I imagine London. We can't have bird's eye views. We've got to do what you've described. So I think that's the beauty of the shared care record, by bringing it together. So I just love that approach of making it hard, because that's the beauty of the shared care record. Otherwise, it's just lots of tabs.
Yep, lots of tabs, which doesn't actually help carers, professionals in what they do. It makes their life, they're overwhelmed by the information. So if data is always going to be a challenge for shared care records, but we hope we have ways to help and support that. I'm going to turn to you. What are the challenges, for another question that's come in, what are the challenges facing shared care records generally? And I know you have a view on this from
yes.
About some of the challenges.
And I think I saw, if I can talk about 2 things in conjunction with each other, I think I saw another question about borders in there. So little old Gloucestershire has, several borders in all directions. One with Wales, of course, which is, international when it comes to shared care records, but we have a lot of rural practices on our borders as well, whose patients travel to different hospitals across the border, and so borders is a big challenge. We haven't cracked it with LICRA. I think we've kind of almost the ship has sailed on solving it regionally. I would say we need that kind of national, how are we going to do this? And it links back to a standardized way of integrating. If we had that, we could link up more collectively. But the other thing that I find really challenging is the there's all these wonderful products being developed at national level. How do they all fit together, or policies or initiatives? And it's kind of trying to understand where they all fit together and where a shared care record, local shared care record, fits into that picture. It takes a long time to get a shared care record from conception to maturity. If in the meantime there's lots of kind of direction changes, it really makes that journey increasingly difficult. So if I talk about things like so we've got GP Connect, we've got shared care record with AI now since the pandemic, thank you. We have the national record locator, and now we have the recent Let's All Converge on the same trust system. All of those are forms of record sharing, shared care records, and each time one of those, how do they all fit together? How do these pieces all fit together? And how do we not trip over ourselves, and how do we not confuse end users? If you're an end user who's got access to all of those tools, and you've got a patient in front of you, which one do you pick?
Yeah, thank you, and I recognise that plethora of national initiatives. Laura, what do you see as relatively still early in your journey? What are the challenges that you see facing shared care records?
One of our sort of challenges we find, I mean, it was touched on earlier, is around sort of digital maturity and the challenges of navigating around existing organisational contracts that they have with their system suppliers for upgrades and fixes and what their roadmaps look like, and to interlink and align with that is really quite difficult. We've been trying to work with our system suppliers to make them aware of what we're trying to do locally, so that can then be factored into their developments going forward. And as I sort of touched on earlier, sort of having a collective of us going to them as a, you know, as a wider group rather than just one ICS, or having 44 different ones going to them to ask the same questions, going as a collective to say, actually, in 6 months' time, we're going to be mandated to do this, or we have to implement these things. This is what we need from our systems to be able to do that. And that is a definite challenge to overcome, because a lot of system suppliers have their roadmaps mapped out for you know, a year in advance, or sometimes 2 years in advance. And things change so quickly within the NHS, and also with the new social care standards as well. The timeframes on that are really short for us to be able to deliver them at a local level. And actually, we need the backing from the system suppliers to be on board with that as well, and them have eyes on what the future looks like and what we're being expected to deliver as well.
Thank you, Laura. Astrid, what else do you see as challenges?
I think pick up on two. So capacity and benefits, probably. Capacity in so many different ways, but Laura, you were just picking up on that. I think around working, well, it's just in so many different places, really. You know, and you look at the labour market more externally to us. You know, it's digital is very, very high profile and really, really busy at the moment. So I don't know how we deal with that, but that's a really, really big challenge for us. I mentioned earlier about our limited development pipelines, and they are limited by so many things. Budget availability, time of the local trusts, all sorts of contributing factors, and yet we've got 100 odd things that we want to do. So that is really, really tough. And I think work with national, work with regional, work with each other, all sorts of ways to try and address that. But it comes back to Laura's opening point about not reinventing the wheel. Well, part of it does. Benefits, we're also, having had a contract for a number of years and having got several years of use, we're in that phase where new things need to start being budgeted for as we go, as opposed to the lovely big push that you get at the beginning from the start of a new program. And I'm delighted that I think ICSs are now certainly my Dorset ICS went to the finance group and they said, where are your benefits? And I think digital more widely needs to be held to account. So we spent a year trying to work on that, and we've got some evidence-based benefits, and we went back and we went back to them and they said, brilliant, could you do some more? As you'd expect. Went back to SLT, who said, brilliant, this is one of the first benefits cases we've seen in and around digital. How is this the first benefits case that we've seen in and around digital? We've got to make it affordable, because as we start seeing changes coming through from the various suppliers we work for, we've got to afford it. We've got the more and more now, what's our value for money? What's our impact? How much are we going to use this every year from this point onwards? And that's something that we didn't necessarily have to talk about in that first couple of years of being. So to sustain the shared care record is going to take investment.
And that investment needs to demonstrate, it needs to demonstrate a return on that investment. And I know the most recent business cases I've been doing for shared care records, we've done a much greater focus on the benefits that are achieved. And in part, we've done that because we've learned from those real life experiences, those user journeys that we've seen people go through over the past 7-8 years, which get integrated in shared care records, have really made an impact.
They have, but again, our experience is we've talked a lot about the impact, but we have to scale it. So it's about who's your audience. If you're trying to encourage a user to start using the shared care record, knowing about, Johnny's failed prescription that completely changed his life is what's going to change it. In front of an SLT, it's not.
Yeah.
You don't get investment based on that. And we've got to change and take our stories and interweave it with, mingle it with hard facts and numbers.
Other shared care records are available. So last question for all three of you, and it's the biggie. So what's the future for shared care records? I'm not quite sure where I'm going to go. I'm going to go to Laura first. Laura, what do you see as the future for shared care records? You've mentioned social care, just gentle hint. Where does shared care records go?
Yeah, I mean, in LLR, we've had social care actually in the forefront of our integration right from the very start. It was something, I touched on it earlier, we've been working for quite a while within LLR of interlinking our different organisations by one way or another. And social care, kind of when we first kicked off with our sort of talking about our implementation and writing our business case, the local authorities were like, we want to be at the forefront of this. We don't want to have this health thing happen, like be pushed on us from a social care of a second thought perspective. So it was really important to us that we were seeing a full holistic picture of a person's journey through all of our services, right through from our sort of health care organisations, and how that person or patient transitions through our services between sort of both health and social care settings. And it is really imperative to get that. So I can definitely see there being more of a push in the areas that maybe it's just health organisations that are on their shared care records at the moment being pushed out into that social care area. I saw one of the questions pop up in the chat, actually looking at sort of what does the access for voluntary and community sectors partnership look like, and that's definitely something that will come up into the conversations. Yes, they might be voluntary or community sectors, but they work so closely with our health organisations, and they have such a huge impact on the people's lives that they work with, that it would be good for them to be able to see a full picture as well. So I can definitely see that coming up in the future as well.
Thank you. And Una, in Gloucestershire, what I sometimes refer to as the supply chain of health in terms of social care provision, in voluntary care sector provision, in the third sector generally, is a huge part of the story in Gloucestershire. What do you see as the future for shared care records? Where's your focus for the future, and where do you hope the focus is?
Sure, yeah. So I suppose I think that I have two answers to that question, really. One is, yeah, absolutely to do that. So today, most of our shared care record solutions are largely a view of information. There's not a huge amount of really good quality functionality going on there, I would say, as a sweeping generalization. And so again, that was a kind of a theme in the questions, I think, is where we need to go next is for that real cross-organization collaboration. And we're talking about virtual wards, transferring care, that kind of patient flow around the system, and our social care kind of managing that. Sort of alerting and notifications, all that needs to be really seamless and really in the kind of face of our end users without them having to go looking and hunting for it. And so I suppose with that in mind, I would say when we were, again, this came up recently in our team, is where we, the vision, if you like, where we need to get to is actually the shared care record is of a breadth and quality and standard that actually it's the first place the user goes to before they dive into their native system. So they get that kind of, here are all the things that I need to know and care about, and gives me that overview right now. I'll dive into whatever it is I'm dealing with in relation, and that's where we need to get to, really.
I conclude with you, Astrid. Future for shared care records,
funny, isn't it? I think Una's picked up. I think there's two things I just want to say. We need as a space to be able to shift potentially in different ways. So at the moment, Una said, we largely come in, you've got more or less some kind of portal, you see it. Do we go more bi-directional? Do we go to more stuff happening into it? Live debate should be a debate. We probably need some of both happening so that we work out which it is. That's my opinion, is that if anyone is one side or the other, I think we probably need to think about being a bit more flexibility to work out where we do go on that potential arc of change. And I don't know. Some days I feel like I'm at both ends at the same time. So that's one aspect. One thing that keeps drawing me. We've touched on borders. We've touched on health and social care. We've touched on EHR. If you look at shared care records through the spheres of an organisation or organisations or users, then that takes us down one route. If we look at it through the person, it often changes every single conversation. Yeah. So how do we keep, and I know we keep saying that, but we don't necessarily make the decisions based on that, because if it's to do with that, then picking up on what Una was saying about normalised record, you'd never have multiple tabs if you're treating Sandy.
Yeah.
You'd have her record and her lifelong record. And that's how we're going to address health inequalities. That's how we're going to keep, I could go off on one about maternity and the lack of maternity or other women's health issues within shared care records. There's not many standards around about that. Yeah. Why? So if we keep it on the patient, I am optimistic that will help us steer it through. And that's also the way that we'll all end up with the same answer. And that's how we'll get standardisation. And it's not because we do have the challenges between health and social care. We do have cultural balances and difficulties to get through.
What a brilliant conclusion. And actually probably brings me to a point I was going to make about today's webinar, which is, as we come to the conclusion of it, and apologies, there are lots of questions we haven't got to today, which we'll come back to, is we spent a long time today talking about the implementation approach. That was today's webinar, specifically about how you start strongly on a journey. When we're talking through with Laura, how you build that shared care record with Una, and how you then create that as particular use, increase in usage as you go through with yourself, Astrid. But Astrid, you ran a very recent webinar under the auspices of Care Record with John Farrington, which really underlined really powerfully the impact that shared care records can have on the individual, and probably more pertinently from John's really strong stories about where harm can come to people when information isn't shared. Today wasn't about that, but that's absolutely what shared care records are all about, and why we at Channel 3, the ladies here today, are so passionate about supporting and continuing to develop shared care records. Andy is going to put into the chat a link to that webinar. I would urge everyone who's listening today to take a look at that. It's a very powerful set of stories about individuals for whom sharing of information didn't happen and the harm that came to them as a result. And it's not an easy watch, but it's a very important watch. Ladies, my thanks to all three of you for today. It's been great insight and great chat, and thank you for, I can just sit back and let you talk because you have such a wealth of experience and insight, so thank you for sharing that with us today. And I hope it's been as interesting for you as it has been certainly for me. My thanks too to the audience today. As I say, there is a number of questions we just haven't been able to get to on the time today, but we will hopefully this is the first of a number of sessions like this that we'll run, and I would love to be able to dive into some of the questions that people have been asking today in more detail. But please don't hesitate to reach out to me if you want to have a more detailed conversation about some of the issues that have come up in today's conversation. Just to conclude, for Laura, for Una, for Astrid, we stand shoulder to shoulder with these guys as they deliver shared care records for their communities and for the people they serve across their different parts of the country. Thank you to you for the work you do. We really appreciate it. And thank you to everyone for being part of today. Goodbye and talk again soon.